I'm Maile Karris, and for those of you who don't know who I am, I'm a clinician at the Owen Clinic, but I'm also a clinical and translational HIV researcher. So over the last couple of years, most of my work has been focused on evaluating and implementing interventions around psychosocial factors that impact the health of older adults with HIV. I've been particularly interested in these sorts of topics like loneliness and social isolation because they've been somewhat ignored in the work around older adults with HIV, and at least in my clinical practice, I can really see the clear impact that it has on the lives of the folks that I care for. Truthfully, I first began interest in this area when the HIV care recommendations changed from having to see patients every 3 months to only every 6 months. I don't know, I think hopefully most of you remember that we were seeing patients more frequently than now. And as I started to transition my patients to that new recommended schedule, the ones that were stable, that didn't have a lot of medical comorbidity and didn't have a other specific reason to see me on a regular basis, I actually was surprised that a lot of them were resistant to that. They would tell me things like, I need to see you at least monthly or at least every 2 months. I cannot go every 6 months without seeing you. And at first I didn't really understand why there was such resistance. I felt that they thought that it would be nice and beneficial to not have to come into clinic so frequently. So I just started asking them, like what they were getting out of these appointments, because I wasn't changing any medications. I wasn't doing any new tests. We were just kind of talking about what was going on. And they answered me with things like, well, I always feel better when I come here, or I just missed seeing you and I needed to talk to you about things. And I think it really hit me when I was seeing a patient, and she actually brought her boyfriend with her, a new boyfriend, and halfway through the visit, he blurted out, he's like, wait, are you her therapist or her physician? And I began to realize that the reason that they wanted to come see me on a regular basis was because they were missing the connection that we had, and that they were lonely. And, based on those interactions and based on what my patients were telling me, I began to look into this concept of loneliness. Specifically, I saw this a little bit more concentrated in more older adults that I cared for, but, I also see it in my younger adults. Lots of young folks come in and cry, because they feel like they don't have anyone to talk to also. So this is something I think that is a big issue, and hopefully I can convince you of that as we talk about some of the data around loneliness. So that's kind of why I'm interested in this topic. I thank my patients for being open and honest with me so that I can come to the realization that this is a thing. And hopefully you guys have lots of questions. The first half of this talk is going to largely be just reviewing the literature around loneliness. And then the second half, we're going to share some data from a project that we have. It's fresh off the presses. You guys are the first to see this, just to kind of think about what the needs are in the community around us. I welcome questions at any time, but I cannot see the chat box. So Jill, please feel free to stop me if someone wants to kind of veer off and talk about something else. Okay, so I do receive funding to the institution from Gilead Sciences and ViiV Healthcare. I've served on advisory boards for Gilead Sciences. So what is loneliness? So loneliness is defined as a discrepancy between a person's preferred and actual social relationships. And this discrepancy ends up bringing up feelings of distress and dysphoria. So you can be lonely even though you're surrounded by a bunch of people. That concept of being in a party with a ton of people and feeling very, very alone. Social isolation is a related concept, but has a slightly different definition. So social isolation is an actual objective lack of contact between an individual and society. But you can also be socially isolated and not lonely. So if you think about like the monks who go on these journeys where they don't speak to anyone, or even other people, not just monks, and they're perfectly happy in their own solitude. So anyway, it's not exactly the same type of thing. Both of them tend to be lumped together when they're being evaluated and interchanged, but they're not exactly the same. And for the purposes of this talk, I will specifically comment on the impact of social isolation versus loneliness and kind of tease some of that out for you guys. So why does loneliness exist in humans? And I have to say, I think my favorite hypothesis, and one that kind of makes sense to me, is the evolutionary theory of loneliness that was developed by John and Stephanie Cacioppo. And that basically proposes that loneliness is an averse cue, kind of like hunger. It is telling you, hey, you know, like you got to pay attention here. There's something wrong and something needs to be acted on. What we do see with loneliness is that it does seem to promote some short-term self-preservation. People who are lonely appear to be more vigilant for social threats. There was a really interesting eye tracking study that evaluated persons who were lonely versus not, and lonely folks tended to fixate on socially threatening stimuli compared to positive stimuli. So like a frowning, threatening-looking face versus a happy, smiling face. So there may be some benefit for having loneliness, at least in the short term. However, just like hunger, if you do not act on reconnecting, when you are experiencing these negative feelings related to loneliness, there are multiple subsequent negative health consequences. In the evolutionary theory of loneliness, Cacioppo goes on to explain, you know, like the way that humans survived the saber-toothed tiger, you know, like, or, you know, like earthquakes or famine, was not necessarily because we had a genetic evolutionary advantage. I mean, there's no way that a human could go up against a saber-toothed tiger and win. But it was our ability, or it is our ability, to connect meaningfully with each other and protect each other as part of a group, come up with a combined plan to face a common threat. And thus, he thinks loneliness tells people, you know, like, hey, I'm out here by myself, I better go connect and kind of meet up with someone so that I do not put myself at long-term risk. Loneliness and isolation are both really common in the US. This is actually a little bit of an outdated study. The most recent one from 2020, this is a Cigna report. Cigna Health has been really interested in this concept of loneliness for some time, and they probably are the folks that are doing the best at tracking this in a broad swath of Americans. But in 2019, about 46% of the people that they surveyed felt lonely or left out. 25% didn't feel that there was anyone that really understood them. And 40% of their respondents said that their social relationships were not meaningful. That's huge. In a more recent survey this year, this survey was conducted before COVID-19. I expect it may even be worse now. They found that overall 61% of respondents reported that they feel lonely at least some of the time. So this is very, very common. And it has been increasing over time. There was a really interesting study in 1985 where they were just trying to describe and evaluate loneliness. About 10% of persons reported that they did not discuss important matters with anyone. They repeated that exact study in 2005, and that number had increased to 25%. So this looks like this is a steadily increasing phenomenon in our culture and society. So I talked about how, you know, like if loneliness is not acted on in the long term, there may be some negative health effects. I think the most notable statistic that I like to share is that people who are lonely have an increased odds of an early death of 26%. And I know that that seems difficult to conceptualize for a lot of people, but that basically is equivalent to smoking 15 cigarettes a day. And it's the same as the impact of obesity on health. So this is a big deal. And, you know, we counsel a ton, right, about smoking cessation. We do a lot of weight loss and exercise counseling, but do we do counseling about loneliness? Are we encouraging our patients to socially connect if we can identify that they are lonely and socially isolated? Not really. And I think, so, you know, I think one of the other reasons I've been interested in this topic is because personally as a physician, you know, as an infectious disease physician specifically, I'm trained to make diagnoses and then treat them with medications. And in the beginning, I didn't really know what to do with loneliness. I didn't know, what do I tell them? What works, like what's out there for them to engage in. So I've wanted to get better at that, and subsequently have now developed this interest and have some research projects in this area. So loneliness is also associated with an increased risk of heart disease, stroke, depression, as well as accelerated cognitive decline in later life. And it's expensive. So Medicare estimates that they spend about $134 a month on socially isolated persons. And ultimately, that adds up to $6.7 billion annually. So this is expensive for our country as well.
Maile, can I ask a quick question?
Please.
How did they come up with that estimate of Medicare spending $134 per month on a socially isolated person? Where does that data come from?
So that actually comes from Medicare, and they looked at people. So they do characterize whether or not somebody is like living with family and has assistance and stuff like that. So this isn't specifically loneliness. This is people who are socially isolated, and basically what they say is it is costs that's related to like transportation to visits, longer hospital stays because there's nobody at home to help take care of them, longer SNF stays, and things of that sort. So that's where that money comes from. It's just this kind of prolonged in-health care versus informal care that you could get at home if you had more family and friends that were able to take care of you.
Thanks.
Does that make sense?
Yep.
Okay. So why does loneliness affect health? So in part, social relationships affect health because it influences health behaviors and healthcare utilization. I think a lot of us experience that when we do a visit with one of our patients and their partner or spouse, and their partner or spouse talks about how, yes, this is how they take their medications. I make sure that they take their medications like this. So there is a little bit of positive medical decision-making that can happen when you have a supportive friend and family around. And that might be one of the reasons why social isolation and loneliness are contributing to these negative outcomes. There originally was some thought that people who are lonely are more likely to have negative health behaviors. But when they've looked into that, it doesn't seem to be significantly different between lonely people and people who are not lonely. They seem to have very similar diets, exercise, substance use. But the one thing that is different between lonely versus not lonely is people who are lonely are slightly more likely to commit suicide. So maybe that is accounting for a small proportion of this increased odds of death. But really, it's probably the impact of stress. So loneliness definitely affects how people cope with stress. And I mentioned 3 different types of stress reactions here. Added stress, loneliness. So lonely people perceive that they have higher levels of stress than non-lonely persons. Differential reactivity, lonely people report having more hassles in life. They report that there's less intense uplifts with positive interactions with people, and they report more stressful everyday events. So having the glasses of loneliness really colors how people view the world in a more negative way. And then stress buffering. Lonely and non-lonely people have equal opportunities to interact with each other, but lonely persons report that the interactions that they have are actually of poor quality, and they didn't provide as much support and comfort as persons reporting who are non-lonely. So there is different perceptions of interactions in people who are lonely. And it's really that inability to adequately manage stress that subsequently results in chronically elevated cortisol levels. They've documented this a lot in some comparative animal models, which have been the basis of some of this evolutionary theory of loneliness. And then these chronically elevated cortisol levels are hypothesized to then impair glucocorticoid receptor pathways that ultimately result in transcriptional changes that cause increased cellular resistance to the glucocorticoid inhibition of pro-inflammatory cytokine responses. This ultimately results in a dysregulated inflammatory response, and the genes that are responsible for this, or these transcriptional responses, are actually known as a conserved transcriptional response to adversity, or the CTRA. This response is not unique to loneliness. So changes in the CTRA have also been observed with other life experiences that are negative and adverse and traumatic. So I like to show this study. I just thought this was such a well done study, and for me, from a translational researcher standpoint that has some background in inflammation, this is kind of the study that sold me on the importance and potential impact of loneliness and inflammation. So 134 healthy but sedentary overweight persons were evaluated. They were divided into who were lonely and not lonely, and they underwent an acute stress test, which included the Trier social stress test, which makes you give an impromptu speech, meaning you show up and they're like, you have 5 minutes and you have to give a speech, as well as doing a mental arithmetic task. So it's kind of a very acutely stressful experience for a large majority of folks. And then they followed them over time with serial measurements of IL-15, IL-6, and TNF-alpha. And here we see in persons that were, so in both populations, they both seem to start with a pretty similar level of TNF-alpha and IL-6. Folks that had higher loneliness seemed to go up higher when they were stressed with both of these markers. And then these markers stayed elevated for a much longer period of time than people that did not have loneliness. So again, speaking to the impact of the CTRA on an inflammatory response to acute stress. They also wanted to evaluate whether or not this loneliness washes out in the setting of other stressors. So is there a specific impact of loneliness even if people are experiencing other stressors? So they repeated the exact same experiment in breast cancer survivors to evaluate if, having this big stress of breast cancer just washed out any type of loneliness signal. But it didn't. And again, we see, most the lonely people and the non-lonely people started out at around the same place with TNF-alpha, IL-6, and IL-1 beta. Again, people who were lonely had a slightly higher acute reaction with the expression of these pro-inflammatory markers, and they also, demonstrated a persistently elevated level 2 hours after they were stressed. So this does seem to promote inflammation in people who are lonely. And now some of you are checking out because you're like, oh, I thought this was going to be a lecture on HIV and I haven't really heard anything except your stories. So let's get back to HIV. There are a couple of unique experiences that some older people with HIV may have that places them at an increased risk of loneliness. Granted, older people with HIV are a highly heterogeneous population. This does not apply to everyone, but I just wanted to talk about how I think about this and how I approach it. I think, at least in terms of the long-term survivors, many of them experience significant losses of peers and partners. For those of you that are around at the time, you know very clearly how that impacted people, how it impacted you potentially. There is a very well-known HIV advocate who famously has said in 1 month during the AIDS epidemic, he attended 40 memorials of his friends that were lost to AIDS. And that is just huge. And what that resulted in is a very rapid depletion of the social network of those persons, as well as the potential development of AIDS survivor syndrome, or the survivor guilt of not being part of those numbers. People with HIV also experience a lot of HIV stigma. When you're older, that's coupled with ageism. And that may really significantly limit new interactions to grow and develop a social network. And if you're a person of color, if you are transgender, if you are a substance user, those are additional stigmas that may be piled upon you, whether it be your internalized stigma about yourself or actual real social stigmas. Mental health issues, particularly untreated mental health issues, may impair social abilities as well as cognitive function that prevent folks from creating and making new relationships that are meaningful. I think we see a lot of medical comorbidity impacting people. If you have incredible amounts of neuropathy or chronic pain, or you've got bad heart failure or COPD, it could be very difficult for one to get out and socialize because it's physically difficult. And then socioeconomic factors. So if you have other needs that you want to see, that you need to seek out before you seek out social interactions, for example, if you need to pay rent or go pay for going out to the movies, you're going to make your rent and you may skip out on that social interaction that you were invited to. So there is some more recent data around social isolation and loneliness in older people with HIV. There is some older data. The numbers and the percentages were much smaller, and they weren't specifically focused on older people with HIV. But Meredith Green evaluated loneliness in about 350 people with HIV at UCSF. As is consistent with their cohort, the majority of those persons were male, and 58% of them reported that they were lonely. Of those, about 24% were mild, 22% moderate, and 12% severely lonely, and that's based on the UCLA loneliness scale. With univariate analyses, she found that people that were lonely seemed to be more likely to smoke, be an at-risk drinker, or have other types of substance use, have low social support, as well as just depressive symptoms, and many reported poor to fair quality of life. But a lot of that kind of washed out in the multivariate analyses. But in multivariate analyses, loneliness was still associated with with poor quality of life, and now with self-reported functional impairment. So some of the things that we were just talking about, you know, if you struggle with physical function, then you may not be able to get out and socialize. And subsequently, that reports to a poorer quality of life. So we also did a study of loneliness. This was a larger group, and it was actually across the country. So I'm involved in a multi-clinic cohort of about 998 participants that spans academia and private practices in California, DC, Florida, Illinois, North Carolina, Texas, Washington State, and I think Wisconsin. So it is a little bit more diverse still. The majority of participants were male. So this is still a kind of a skewed sampling. And in our study, loneliness was correlated with some things that we would expect. So for example, not being in a relationship, not making, you know, like a livable salary, living alone, having anxiety or depression, or having lots of comorbidities. As well, we also saw that loneliness was associated with lower quality of life. But a couple of things popped out that surprised me that I thought we need to think about, particularly in the context of HIV. I was surprised that having a 4-year college degree was associated with being more lonely. I was worried that loneliness was associated with poor HIV medication adherence. So this may be impacting our patients in other ways than just the inflammation that I had previously talked to you about. But the most interesting thing of this study to me was that we stratified the older adults in this population. And for those of you that don't know, in the HIV and aging world, we consider someone with HIV older at 50 years. And that's historically because the epidemiology suggests that people with HIV at 50 have similar comorbidities than people who do not have HIV at 60. So there seems to be this 10-year early aging phenotype. So people that were aged 60 years or older reported significantly lower loneliness than the persons that were 50 to 59. And this surprised us because we weren't really expecting it. I think we have a lot of hypotheses about why that might be the case. So what's going on with this difference between the younger and older old that we saw, at least in our study? And are there any lessons to be learned from the literature that already exists? So there have been several positive factors that demonstrated a modifying effect on loneliness. I think if you've gone to any other loneliness lecture at UCSD, you've probably heard that wisdom is one of them. So Dilip Jesse has done quite a bit of work with looking at the inverse relationship between wisdom and loneliness. He's looked at this across all sorts of ages, between college students, older adults, working folks, and there is consistently this inverse effect. Jill, you're texting me. Oh wait, are you guys see? Oh shoot. I'm not sure if
It was from a while ago. Ignore. Keep going.
Oh, sorry. Okay.
Keep going.
Sorry. Sorry. Okay. Sorry. So wisdom does seem to be protective against loneliness. Resilience also seems to be protective. Nostalgia, which basically is, telling stories of a wonderful past life or reliving, positive memories from your past, also seems to be somewhat protective against loneliness. So when you're stuck at that family reunion and that uncle that you don't really like talking to sits next to you and tells you, the story about some amazing thing that happened to him when he was a child, sit there and listen, because it's helpful. It does help to protect against loneliness. And the other factor that's been studied is eudaimonia, and basically what that means is it's defined as like a sense of life purpose. So I have well-being because I have a great sense of life purpose. That is also very protective against loneliness. For those of you who care for older adults with HIV, particularly the older olds, certainly I see a lot of this in all of them. And I'm wondering, how do we get this to folks that are younger? I'm going to stop there and just ask for any comments before I kind of move on. Anyone have any questions, thoughts? Want to share personal experiences?
Jeff Taylor did make a comment. Jeff, I don't know if you wanted to say it. I think it was a really nice point that I don't think Maile can see. So I don't know if you want to mute yourself.
Sure. I'm on and happy to share it. I was just saying that what we're seeing now is that so many people are being forced out of their neighborhoods of economics and higher housing prices. So they had to leave their networks and community and relocate somewhere else, and because they can't afford it, basically. And so we're seeing, and this is, of course, a common phenomenon in Palm Springs. So people with less resilience and more social anxiety can't reestablish those networks easily, and we're seeing a lot of loneliness and isolation in those folks.
Yeah, I can see that. Thanks, Jeff.
Maile, and
anyone else?
Yeah.
Oh, yes, please.
And probably Dan Lee can speak to this better than me, is that you need, as family practice, infectious disease, internal medicine, we are not trained in how to shield ourselves from being caught up into the story like psychiatrists are. I was being a psychiatrist the entire time that I was in practice, and I hope I was doing what you're talking about now. And it helped me be able to be there for the patient, how they're not to be sucked in. And I'm using this into what's going on. I was there for the patient, however, I tried not to let it affect my life once I left work. And this is something you have to worry about if you're really concerned. And like I said, Dan Lee can probably speak to this much more than I can.
Yeah, I agree with you. I think it is hard. I think many of you know that I'm not full-time at the Owen Clinic. Personally, this is my story that I share. I think that protects me to some degree from burning out, kind of like what you're saying, Larry, from taking too much of that home, because I have a variety in the things that I do, and that is not my all day, every day experience, because it is hard. It's hard not to want to, take someone home who's struggling, or, you know, like invite them to stay at your house when you know that they're losing their housing. We can't do that. And it's incredibly difficult. And you're right, we don't really know how to best protect ourselves from feeling that struggle. For me, I translate it into trying to find solutions through research and getting projects that I think would help folks at a global level that I am not able to do on a one-on-one level. So I'm going to talk in a little bit about a project that we're doing, and the second half of this talk is going to just be data about that project. But that's, for me, how I kind of deal with that. It is hard. It's hard. Okay, I'm going to move on. So what can we do about it? There's lots of different types of interventions that exist around loneliness. Social facilitation, I think cognitive behavioral therapy social cognitive behavioral therapy is another, probably the best supported by literature, but hard to do and hard to access. Animal rehabilitation, where, you know, like you bring in animals to nursing homes just so that older adults can connect with something that's cuddly and loving. And then health and social care, like IHHS, for example. Befriending interventions where there's an intervention in Hollywood where I think this is supported by actors through charity, but basically it reaches out to retired people who work in Hollywood, from, you know, acting all the way through set design and whatnot. And they give them a weekly phone call just to check in and make sure they're doing okay. And then leisure skill development, like developing a gardening club or getting people together for a book club or a bowling game or something of that sort. And these are all great. Most of it is not supported by much evidence, except for, again, the psychosocial therapy. But is there a way that we can kind of try to integrate aspects of this and some of the issues that we talked around that are impacting people with HIV in a more comprehensive way? So this led to the development of a project that we're now going to be talking about. We have funding to establish or pilot a village in central San Diego. And forgive all those folks who've heard me give this talk about 500 times. I'm just briefly talking about it for the new folks. So basically, for those of you that are not aware, the village model is a model that basically was started by older friends who lived in Beacon Hill about a decade ago. They didn't want to be pulled out of their neighborhood. They wanted to continue to live there, but they were recognizing that as they aged, it was becoming more difficult for them to accomplish the tasks that they would need to do to age independently and to remain in their own homes. So they decided that they were going to get together, all chip in an annual fee and pay an administrator that could help to coordinate services for the different village members, as well as meet needs. And this administrator primarily created socialization opportunities. So they would host and design different social events. And they also created opportunities for the individuals of the village to use their talents to overall benefit the village. So if there was for example, former chef, and then there was another village member whose partner or spouse maybe passed away, and that person was the only person that, you know, like made all the food, that administrator could potentially connect those two individuals so that, you know, the chef could maybe help teach or help feed this other village member. And overall, their role was to promote interactions between the members and develop trust. And this grassroots movement has really spread across the US, and there's currently more than 200 villages and many, many more in development. There is a national network. They have a conference once a year where they talk about this village model. But because this is a grassroots movement, it's not been very well studied. And there are a lot of known limitations. So we don't really know if the village model works. When asked, the majority of members say that they do feel or they do believe that they're more likely to be able to age in place or stay in their own home as they were getting older, but lots of limitations. So in a community, people with poor health are much less likely to be associated with a village. So folks that maybe need the most assistance are not there. There's a really significant lack of socioeconomic diversity. The villages are mostly populated with white women, not a bad thing, but, you know, will this work if we're going to apply it to a broader, more diverse population of people? there's lots of questions about, is this a sustainable movement and can it actually be disseminated? Because it does require this need to pay an annual fee to get operations to be facilitated. And if you really want to have an effective administrator, the village also needs to provide opportunities for that administrator or the leaders of the village to develop that skill set and develop a greater knowledge of the resources that exist for the members beyond just the village. So they also need to know, what does the state offer, what does the county offer, what are other programs that are complementary to what we're doing offer, and can we also leverage those to assist the village members in general. So what we're doing to try to overcome some of these barriers, to mitigate the need to pay annually and have leadership development and then develop this research knowledge, we are partnering with the San Diego LGBT Center because they are longstanding, well-funded, and highly research knowledgeable and already doing a lot of this work for older adults with HIV. To evaluate the effectiveness in a socioeconomically and diverse population, we are opening our village in central San Diego, which has the highest density of people with HIV, but is also fairly economically diverse. And to enhance real-time responsiveness to needs, meaning, if someone needs something right away, it takes a while for them to call the administrator to then call around and then find someone who can meet that need, who can then make it over to the house to do it. What we want to try to do is use a hyperlocal social app to display and meet needs. We also are interested in our village being intergenerational and not just with older adults, and we are hoping that having a hyperlocal social app, the one that we picked also has an aspect of gamification, will engage younger adults to also participate and be involved in our village. So that's our village in a nutshell. Just real briefly, our aims, so how we're going to do this is, aim one, we performed a very large community needs assessment. We are in the middle of evaluating determinants of using a hyperlocal social app and developing a village. We're doing that using focus groups, both asynchronous and synchronous focus groups. All of it is virtual though because of COVID-19. And then we are going to be developing and evaluating the establishment of a village in central San Diego. And some of our outcomes, the primary outcome are our implementation outcomes of acceptability and feasibility, but we also want to look at social network characteristics over time, psychosocial factors such as loneliness, depression, anxiety, perceived stress, substance use, and HIV stigma and ageism. And then I'm also interested in clinical outcomes primarily because I think if we want buy-in at a broader level, we should look at some of these things that other funders are interested in. So I want to see if being part of the village actually changes adherence to an HIV primary care plan. Are they coming to more appointments? Are they doing better with taking their medications? Have they had any improvements in their A1C? Also want to look at quality of life and self-reported function. Okay, so here's the meat. I am briefly going to show you data. There's a lot of it. I did not pick all of it, but I apologize ahead of time. Please feel free to stop and ask questions. The data is very rich. I'm just going to highlight things that I think are important from it. So we conducted online surveys between October 1st to February of 2020. I want to specifically point out that this was before COVID-19. So this captures the needs of people before COVID-19. I expect things will probably be very different now, but this was recent, but again, before COVID-19. About 3,600 surveys were started, of which 3,155 were actually completed. And the data that I'm showing you is going to be stratified by HIV status and age, and we kind of separated it into three general groupings. Youth is 18 to 24, adults are 25 to 49, and older adults are 50 plus. And we evaluated general demographics, housing issues, social support, physical and mental health, and the ability of persons to get their basic needs met.
Maile, just a quick question, because it's a huge number of surveys. How did you get them out there? How was it advertised? How were people compensated? How did you get such a good return?
So we worked with the center, honestly, and I have to really commend the center because they worked hard. They had it in their newsletters. They were pushing it in at the center, but we also had it up on Facebook. We were promoting it. I don't know if Marvin can maybe even speak in a bit more if I'm misspeaking, but we promoted it across multiple platforms, including social media. It was a fairly slow uptake in the beginning. I think we were getting like 50 to 100 a week or so, and then it kind of like ramped up. You know, like I think as we hit a critical mass of people that were aware of it, more and more people started participating because it was easy. We reimbursed people with $20 when they completed the survey, and you didn't necessarily need to complete the survey to get the 20, which is why I think we have this discrepancy between surveys started and surveys that were actually completed. Some people were clearly just in it for the money. But yeah, you know, I think the center really pushed this, and I have to give them 100% credit for this completion rate because I know that they worked really, really hard to get this done. So partnering with community is good, is basically the bottom line of that.
Dr. Grillotti just asked, could you complete it twice for, you know, $40? Was there a way, could it stop you? Did it stop you if it knew that you'd already completed it?
So we looked for, so we were looking specifically for bots. It doesn't stop you from completing it. You did have to, you know, enter unique names and addresses, and we did look for duplications, and then if we found it, they didn't get it. But I don't actually think we had anyone that clearly made a duplicate. But yeah, you know, we can't say 100% sure that there's no duplicates in here. We also can't say that there's no bots, but we don't think so because Heather Pines is a co-I on this grant, and she went through the data and was looking for, you know, signs of that, same answers and things and whatnot. So we don't think so, but we cannot confirm.
Thanks, Maile.
Sure. Any other questions? Okay. So again, sorry, this is lots of data. Just going to kind of highlight some of the big things. One thing to note is that most of our study participants were male. Really, the only groups that were a little bit more equitable were in the adult HIV positive population, which I was excited about to see, as well as the older adult HIV negative population, but still that skewed to be male. So that is one limitation. You know, we're really capturing mostly the needs of male participants. I think if you look at sexual orientation, most of them were also LGBT. So that might be one of the, maybe the good and bad things of partnering with the center is that they definitely, you know, we targeted the population of people that they care for and, or that they support. And I think that that is one of the reasons why we have this somewhat skewed gender and sexual orientation population. As far as other demographics, overall, I think it was fairly representative of San Diego demographics. As far as race goes, we had slightly higher representation from white persons in the HIV negative adult groups, 73%. I think that number is supposed to be close to like 50. But overall, it, you know, like was fairly diverse. There were a lot of Latinx HIV positive youth. So that was also a fairly skewed population. As far as relationship status, the majority of respondents were in a long-term relationship, either married, a domestic partnership, or had a significant life partner as observed here. But there was also, you know, like a significant amount of people who were single. In terms of education, it also tracked mostly with San Diego demographics, except there was a significantly higher proportion of adults HIV seronegatives having a bachelor's degree or higher. So 65% is much higher than the San Diego demographic. So we maybe captured a more educated population. We also, I think, captured also most people were working, HIV seropositive persons, both adults and older adults, were a little bit less likely to be working. I think we also captured persons that were slightly more economically advantaged as well. So these are higher rates of a household income of $50,000 to $100,000 than would normally be found in San Diego demographics. So slightly skewed to maybe the more educated and slightly more economically well off. Again, that might be a limitation of using the internet and an internet-based survey to collect this information. We did offer paper surveys that could be accessed at the AVRC or the center, but very few of those were actually done. So housing, regarding housing, a lot of the people actually own their own house. And I think this is much more true for older adults. So if you're 50 and older, you're much likely to own your own home. One of the standout groups in this population to me was the HIV positive youth. So they were more likely to be renting rather than living with family compared to their counterpart. And that to me, I thought was very stark. There were also a lot of differences between the HIV negative and HIV positive adults, while the older adults, regardless of HIV status, seemed to be more similar. But overall, this population seemed to be fairly stable regarding housing. And we also captured some open-ended comments, and the first one is in regarding to potential barriers towards retaining and obtaining housing. This is only done with adults, so the adults in the older adult population. And as you can see, it's pretty similar. So in the adult group, income was a primary concern for retaining and obtaining housing. There also was more talk in the adult group with supporting children and their children's families, as well as ongoing employment. Job here is pretty large. And in the older adult group, we start to see concerns about social interactions, and deterioration of health as being some potential barriers to retaining and obtaining housing. One common theme across all ages, youth, adults, and older adults, that actually surprised me. I wasn't expecting this, and I'd love to hear comments from folks. Was concerned that the community that people were living in was not actually welcoming. And I'm going to just read you quotes from different responses in each age group. So one person from the youth group said, "I feel a sense of insecurity in the neighborhood. They look at me in such a way as if I am cursed." An adult said, "Coming out isn't something you have to do once. There's no huge sigh of relief when everybody knows." And an older adult said, "I'm afraid my neighbors will kick me out." I was surprised about that. Anyone have any comments or thoughts?
Maile, were these people who were living with HIV or were
this is all comers. All comers.
But so you don't know much
participants
about these. You don't know if they're gay or you don't know much about.
I don't. Well, we do, but not for this analysis. So I do want to remind you that the majority of the respondents were LGBT.
Yeah, I mean, to me, those are two key factors just based on what you said. Sort of and I've talked about this with some of my younger patients, the idea of double disclosure, which is not only coming out in terms of your sexual orientation, but then having to, share if you want to, that you're living with HIV. And I don't know if it pertains to these individuals, but I do think those are things that are really complicated for a lot of people throughout the lifetime. It doesn't just happen once. It's a lot. So those are just my thoughts. I would want to know more about the people, but I'm guessing that may be part of it.
Yeah, Jeff, you had alluded to this a little bit earlier. Do you have any additional comments or thoughts?
Sorry, I had stepped away. Can you repeat the question?
Oh, it's okay. Actually, I just realized I'm super behind, so I'm going to skip ahead. Sorry, guys. So sorry, I'm super behind. I should have talked more faster. Anyway, let me just kind of show you a few things. This is emotional well-being. In general, people felt their emotional well-being was okay, and some general trends as you're looking through these multiple graphs that I'll show you is that older adults, regardless of their HIV serostatus, seem to have very similar reporting as far as like their emotional well-being and other things. Compared to HIV seronegative persons, HIV positive adults seem to do worse. And then in youth, HIV positive youth compared to HIV seronegative also seem to struggle more with the multiple things that we're going to be showing you. Let me skip through some of this. I'm so sorry, you guys. I was not paying attention to the time. I'm just gonna try to, so I just want to mention a couple of other things. So we asked some questions about like whether or not that participants have opportunities for friendship. I think as you get older, that is more difficult. So older adults, both HIV negative and positive, reported that was hard. And again, compared to the HIV negative adult, HIV positive adults seem to struggle more with finding new opportunities for friendship and connection. As far as rating their own personal physical health, again, we're seeing, like HIV positive adults, HIV negative, and HIV positive older adults look really similar. They seem to really be struggling with some of the same things, or feeling like they're struggling with some of the same things. Let's see, talked about sex life a little bit. So this is another thing that surprised me. So I just want to briefly mention, we asked a couple of questions about substance use. So we asked if our participants were concerned about their use of tobacco, marijuana, and alcohol. Our HIV positive youth were very concerned about this, as were, like our HIV adults and older adults. But what surprised me even more is we then asked about whether or not they were concerned about their ongoing use of illegal drugs. And there were a lot of very serious concerns again in this group of HIV positive adults, as well as older adults, regardless of HIV status, and the youth. So this was not something I was expecting to find here, the use of substances either to cope or whatever, like there does seem to be quite some concerns about this in the community. Skip some of the stuff. So then self-sufficiency. So again, I have a whole bunch of slides about how able are you to afford different things, and they look pretty similar. And I think that one of the reasons we're seeing, not much of a struggle for the population that we surveyed is because, again, they're a little bit more educated and they're a little bit more economically stable. So I'm not sure how reflective these self-sufficiency questions that we asked are of the general community that we want to capture, but I kind of just want to show them here to demonstrate that in general this population seemed to be pretty capable, with the folks that were struggling the most being HIV positive adults and then the two groups of older adults. So you will see this do multiple things. Can you afford your food? Can you afford household items that you need? Can you afford health insurance? Can you afford your meds? And then do you have sufficient retirement funds? So these last two are also interesting. We asked participants what was the most significant problem that was facing them today. Again, this is pre-COVID. I think if we did it now, we would see more COVID questions and maybe more job questions. And these looked pretty similar between the adults and the older adults. So you see income, housing, loneliness. So they look to be sharing similar problems, regardless of what their age were. Youth did not complete this, so we don't have a comparison for them. But things were a little bit different when we asked them, is there one thing that you would change about your life? And adults were still very primarily concerned about things like money and debt, where older adults started to be more concerned about friends, socialization, and their personal health. So there was a little bit of a shift into what they were looking for versus what adults were looking for. So general takeaway, people are looking for a welcoming and supportive neighborhood community. Again, these slides will be made available on the AVRC website, so I'm sorry that I couldn't go into more depth with all the data. It will be there. We're going to be producing a white paper that will be made widely available to anybody who is interested. Just email me and we can get it to you. Probably won't be available for another month or so because we want to do more statistics. But there also appears to be a need to create opportunities for adults with HIV and older adults to meaningfully connect with each other. a lot of the respondents expressed concerns about their current substance use. Older adults, regardless of their HIV status, expressed concerns about their emotional, mental, and physical health. HIV positive adults seem to have a greater need than HIV positive older adults in some situations. And it is also clear looking at the data that HIV positive youth are a very vulnerable group that we need to continue to engage and help as they're going through their lives. So some limitations, convenient sampling. We did not target sampling to a broader population of persons, and this was only available in English. Those are major limitations that limit the interpretation of the data. Next step, we're currently doing our focus groups like I talked about, and we will be developing our village, which we hope will launch in November. We are specifically working to sort out how are we going to manage this in the context of COVID-19? How are we going to help people connect when they can't be in a big room together because of COVID-19? So acknowledgements, I really want to thank all of the older people with HIV who were brave enough to share with me that loneliness is a thing. I want to thank Jeff Taylor, who actually gave me the idea to do this village model in the first place, as well as our Platinum Cab and our AVRC Research Cab, who also, contributed significantly with a lot of feedback to me. Our second act team involves the folks at the center, as well Sarah Marconitas, Elisa Barnett, and Robert Roshan, as well as many amazing people at the AVRC, Mike Dazinski, Jordan Silva, Marvin Henishiro, and Joe have all been incredibly helpful. Dilip, Jesse, and David Moore have been mentors. And then lastly, I'm just going to throw a quick plug for my group behavioral therapy versus group education for chronic pain in older adults study. It's COVID-19 friendly, 100% virtual, meaning you can participate from home. I am incorporating a lot of the concepts that I talked about into this behavioral therapy. I'm specifically interested in improving social well-being to evaluate if it enhances or improves chronic pain. Okay, questions? I know, I'm sorry, there's only 2 minutes. Does anyone have anything to say?
Yeah,
or have any other
chat. If anyone wants to make a comment and unmute yourself, we have a couple of minutes. Maile, this was awesome. But yeah, let people unmute themselves if they want to make a comment. Okay, well, thanks everybody. And Maile, again, thank you. I think this was a really interesting talk, and probably we'll be able to dive into this data with you more at a later date and look forward to the white paper.
Yeah, we will have a formal presentation of this data, and I'm happy to send it to the AVRC listserv, so just keep an eye out for that.
And I just want to remind everyone that we'll be having a really exciting talk next week by Dr. Dave Grillotti on coping in the COVID-19 era, a talk that has been much anticipated. So it should be really interesting. But again, thanks, Maile, so much for this. And I think that's everything. Hope everyone has a good and safe weekend. Wear your masks.
Thank you, Jill.
Bye-bye.